Hello, everyone. I'm Dr. Zahid Ahmed. I'm the co-chair of the Racial Equity, Diversity, and Inclusion Committee in the Department of Medicine at UT Southwestern. And it's my pleasure to introduce the first speaker in our Global Diversity Awareness Month series. Dr. Fiona Strasserking is going to be talking today about peripartum cardiomyopathy in Zambia. She did her bachelor's degree at George Washington University, majoring in health sciences. She then went on to medical school at the McGovern Medical School in Houston. And she did her internal medicine residency at WashU, then did a fellowship in cardiology at Vanderbilt. And she is now joining our faculty. This year, she joined our faculty. So Dr. Strasserking, we're looking forward to what you're going to talk to us about today.
Thank you for that kind introduction, Dr. Ahmed. And I wanted to thank the Department of Internal Medicine for allowing me to participate and also to give me a forum to discuss our findings from this study. So this work was undertaken during my Fogarty Fellowship year in Zambia, which was a year I took off from my cardiology fellowship to work with the medical community there. So I have no financial disclosures. And I think for our talk today, we'll focus on just a few things. We'll have a short case presentation and then a brief overview of what peripartum cardiomyopathy or PPCM is. And then we'll discuss the work we did in Zambia and what management strategies we utilized and also what the next steps are going to be. Okay. So for our case presentation, we have a 37-year-old woman with no prior medical history who presented to the hospital 41 days postpartum after delivery via C-section of twins. She had been complaining of 2 to 3 weeks of shortness of breath, orthopnea, non-productive cough, and abdominal pain. So as part of her evaluation, she got an echocardiogram. As you can see here, she definitely has severely depressed left ventricular systolic function. Her right ventricular systolic function also appears to be mild to moderately depressed. And her LV cavity size is not too large, I wouldn't say maybe mildly dilated. So based on her medical history, her echocardiogram, and a negative coronary angiogram, she was given the diagnosis of peripartum cardiomyopathy. Okay. So going back in history, this is the earliest documentation I could find, and this was at the University of Edinburgh in the 1850s, where the unfortunate Mrs. McFarlane presented 3 months postpartum and had profound heart failure symptoms and ultimately died a week after her admission. So what is PPCM? Well, according to European Society of Cardiology Working Group, it is defined as an idiopathic cardiomyopathy presenting with heart failure secondary to LV systolic dysfunction towards the end of pregnancy or in the months following delivery, where no other cause of heart failure is found. I think this poses somewhat of a little bit of a challenge for patients who have PPCM towards the end of the pregnancy, because the symptoms of this disease overlap with the normal physiologic changes that happen towards the end of pregnancy. So a lot of patients, I think, potentially could be missed. So in order to diagnose PPCM, the patient must have an LVE of less than 45% with or without ventricular dilatation. So who gets this disease? Well, we have a lot of data from small studies, and what has been noted is that women of African descent seem to have a predilection towards the disease. People who have a history of preeclampsia or current preeclampsia or gestational hypertension are at a higher risk. Patients who've had multiple pregnancies or twin pregnancies also tend to be a little bit higher on the risk spectrum. And older maternal age, family history of heart failure, and even more concerning is patients who have prior history of PPCM. So these are the patients who have been noted to be at higher risk for the disease. What causes the disease? Well, we don't know, but we think that it's possibly a dysregulation of the normal hormonal changes that happen during pregnancy that result in myocytes and vasculature perturbations. And there's also been some studies looking at genetic predisposition with the titin gene. And there's a speculation that women who have a history of PPCM, who have a family history of heart failure may have a predisposition to heart failure, and then pregnancy is a double hit, which could potentially lead them to manifest the disease itself. So those are the things that we're thinking about. Okay, I'm going to turn my video off because I think it's a little bit choppy, and I apologize for that. Okay, so what do we know about this disease in Africa? Well, there's been some potential, some studies have been done, population studies, not a lot, because the number of participants in these studies have actually not been very high, because it's very hard to get patients who live in remote communities to come to the hospital sometimes, and sometimes when they present it is quite late in the disease process, or sometimes they don't even make it to the hospital. But Dr. Kayere and his group have the largest cohort in Africa, and that is in Nigeria, with the vast majority of patients in northern Nigeria. So they, over the period of 17 months, prospectively enrolled about 240 patients with PPCM diagnosed between the 20th week of gestation up to 5 months postpartum. And they described what they thought were common risk factors and outcomes at 6 months to a year. Another cohort we have in Africa is the ERP PPCM study, which is conducted by the European Society of Cardiology. This is actually a worldwide registry, and of those, you can see about 213, which is about 29% of the total cohort were from Africa. And they had data to compare characteristics and outcomes between Europeans, Africans, Asian Pacifics, populations, and Middle Eastern women. And they did note that the longest delay to diagnosis was among African patients. They also noted that the African patient tended to have larger LV dimensions, at a higher risk of not being on any or very little guideline-directed medical therapy at baseline. And also, unfortunately, about 30% of them persisted to severe LV dysfunction and death. So what I was able to do, based on the limited data we have in Africa, was compile this table that described few characteristics and outcomes of among patients with PPCM among different countries in Africa. So the Nigerian cohort, which we have here, had 244 participants. That was a peace registry I mentioned earlier. And the age of the participants were in the mid-20s to late 20s. Average parity was 2 pregnancies. See, gestational hypertension and preeclampsia were not very prevalent. This is by no means a comparison table because the methodology for each study was different. This is just a summary of the findings, so please don't compare the data here. The African cohort of the EROP study, which was also compiled from different countries in sub-Saharan Africa, they found very similar age groups among the women. They had multi-parity, was about 78% of the women were multiparous. And then gestational hypertension was about 33%, and then preeclampsia about 21% of the participants. What was very interesting for me was the length of time from delivery or symptom onset to diagnosis. We can see among the Nigerian participants about 7-month delay, and that was usually, I couldn't get a clear explanation, but I think either patients did not present quickly or maybe had been given a different diagnosis than PPCM initially and then sent to a different facility where they were given the correct diagnosis. And then the rest of the EROP, the African cohort, the average time to diagnosis was less than a month. These other studies were actually quite small. Again, the methodologies were different, and we didn't have a lot of data from the markers that I was interested in. And so I would just say that this was done, and we did have some baseline echo data and the recovery rates. And again, depressingly, the recovery rates among Nigerians and among this AROP cohort were quite low. And recovery was defined as improvement of left ventricular systolic function to greater than 50%. Again, at baseline, we can see that their EF in general were also quite low. Okay, why do we care? Because in the big scheme of heart failure, this is actually one of the etiologies that is not very prevalent. At least we don't have big numbers. So why is it important that we actually look at this problem and come up with ways to either solve it or mitigate some of the implications of it? Well, I think for my part, it was that the mortality among patients who were in developing countries was actually high. So this is a meta-analysis that was done, published a few years ago, that estimated the prevalence of risk factor and MACE in developing countries. And I hate to use the word advanced, I'm gonna go and say developed countries, in women with PPCM. What they found was that among the women who had PPCM living in developing countries, the mortality rate is about 14%, right? Compared to about 4% in advanced countries. So there's a wide discrepancy here in outcomes, and it seems to be geographical. So is it because they have more access to better quality care? Is there some genetic predisposition among especially African women to have this problem? And they also live in poor communities, which is like a double hit for them as far as outcomes. Is that why the outcomes are so low? Well, I think that's something we'll be investigating here. So another reason why this is important for me is the outcomes. When appropriately managed, women do very well. As we can see, the IPAC cohorts in the US, about 71% had LV function recovery, which is LVEF over 50%. In Germany, over 95% were able to have normal EF after 5 years. And I'm sure after 5 years, the IPAC cohort also probably had higher numbers. And this is compared to Nigeria, where after 17 months, the percent of LV function recovery was still less than 25% and even lower in South Africa. So I think there's a potential here for us to intervene and improve this outcome, because we know it can be done. These patients do very well. They also have access to the prescription rates for guideline-directed medical therapy are also quite high compared to these patients in Nigeria and not as much the patients in South Africa. So if we can correlate and say, well, these patients in the US and Germany are getting appropriate guideline medical therapy at high rates, could that translate to improvement in outcomes in Africa too? Well, so that was the question I had that prompted us to do this study in Zambia. So our goal was to describe the characteristics of women who have peripartum cardiomyopathy in Zambia, and then get some information on their 6-month outcomes. So what we did, we went to the University Teaching Hospital in Lusaka, which is the largest referral center in the nation. And I utilized my many years of skills as a sonographer by volunteering to work in the echo lab, because they were quite overwhelmed and understaffed. And during the 5 months between February and June of 2021, 158 women of childbearing age presented for echocardiograms with an indication of heart failure. So they either had indication of congestive heart failure, biventricular heart failure, some heart failure symptom. Of those, 45 met inclusion criteria into our cohort. 43 of those were new, and 2 of those had prior diagnosis of PPCM with persistent abnormal LV systolic function. Prior to the 6-month follow-up, 4 were lost. They had relocated to other regions in the country, and 3 died. 2 died in hospital at their initial admission when I met them, and 1 opted for more traditional methods of management and unfortunately passed away. So at 6 months, we were able to follow up on 38 people. I know this is a small number, but keep in mind this was also during the COVID pandemic where access to the hospital was quite limited. So I don't think it is too far from other studies that have had much longer time for enrollment. So of the patients that we enrolled, we were able to get some data on their baseline characteristics. The average age was about 33 years old, which is older than we saw in some of the other studies that we discussed earlier. Average parity is about 3 to maybe 6 or 7 pregnancies. Almost 100% had access to prenatal care, which is actually quite impressive. And also probably an opportunity for us to find, as far as intervention, a site or a point in their care where we can engage these women, teach them about what to look for, and then plan for follow-up. So that's one of the things that we're discussing. And then what we saw from symptom diagnosis, from symptom to diagnosis was about 2 months on average. We had 1 patient who was about 8 months out because she had been to many different health centers and unfortunately was unable to get the correct diagnosis quickly. Of the patients we saw, about 18% had a family history of heart failure. And then what was surprising for me was the number of patients who had hypertension, gestational hypertension, and postpartum hypertension that persisted to postpartum hypertension. After living in Zambia for a month, I realized that maybe some of the habits, the sodium intake among the people I met in Zambia was quite high. So I don't know if that was potentially one of the reasons why the rates of hypertension among the nation was so high. And then about 22% had preeclampsia, and also 22% had required C-section for delivery. So on presentation, we did note that the vast majority of patients had very typical heart failure symptoms, dyspnea, orthopnea, PND, and lower extremity edema, which was not uncommon, and the vast majority were actually NYHA class 4. So the initial echocardiograms were done, and as you can see here, the LV dimension, this was all biplane. The LV dimensions were actually in the severe range for these women, and also the EF was in the moderate to severe range. So these are all the median values as far as the LV volume and also the LVEF. And again, we can see 79% presented with class 4 NYHA functional status. So at this point in my study, my goal had been to enroll our patients and then continue to enroll for as long as I could, and then just come back in 6 months and do a follow-up. But what I noticed was that the vast majority of these patients did not have close follow-up. There was one cardiology clinic at the University Teaching Hospital that was completely overwhelmed. So them getting in to be seen on a regular basis, frequently, with close follow-up was going to be a challenge. So what we did was we worked with the local medical community, and we established a heart failure clinic just for these patients. And I was able to get my medical license, and we had very close follow-up. We actually reduced the hospitalization rate among these participants, because usually they would go home quite sick, not hyvolemic, still decompensated, and then come back right away in a week with just heart failure symptoms. So being able to come to clinic on a weekly basis, mostly initially, and then as time goes on, they were able to spread out to maybe monthly and every few months, actually helped them from being hospitalized, which was I think, a very good thing for the patients who hated being in the hospital. So after we decided that we would like to do something other than just collecting data, we wanted to be able to intervene because we had the skills to manage this disease with what we had in Zambia. The first thing we decided to do was to go to the pharmacy and ask them, what medications do you have? So the government of Zambia actually purchases medications for the pharmacy, and based on an income level, you could get care and medications at little or no cost. And most of the women in our cohort were actually fell in that category where they were able to participate in this plan. So the pharmacy had available Carvedilol, enalapril for ACE, and furosemide. Those were the three medications that were available for heart failure management. In the private pharmacies in the community, MRAs were available, but ARNI, SGLT2, and any advanced therapies were just not an option. So we had to figure out a plan where we could manage these women with what was available in the community. So now, having determined what medications were available, and next steps were to what do we need to do to get the largest number of participants in the study, and also, more importantly, how do we make sure that patients are given the right diagnosis early and treatment was initiated quickly? So we prioritize OB consults, which I end up seeing, and echocardiograms for the OB patients. So I might get called like at 2 in the morning to go see a patient in the OB ICU who they thought had heart failure. We had our numbers posted. We engaged the nurses, we engaged the pharmacists, the registrars, everyone who participated in care of our OB patients. So they knew that we're ready, willing, and available to take care of their patients. And I think that helped a lot with our recruiting and also helped a lot with the outcomes for the patients. And then we did establish our heart failure clinic, like we discussed earlier. And this was a weekly clinic where the patients would come in even if they didn't have an appointment, they would just call my research nurse and she would have them come in, and we manage them. Some of them required IV diuretics in clinic because they didn't want to be admitted, but there were no beds in the hospital. So it was just trying to find ways around the system that we had in place. And then the one thing that was a priority for me was, how do we get our patients engaged in their care? I felt that we could prescribe as many medications as we wanted, but if the community, the patients, their families did not have a buy-in, it was unlikely they were going to be compliant. So we developed a strategy during the clinic visits. They came with all their medications at every visit. We discussed the effect of every medication, the side effects, potential side effects, what to expect. We gave them ownership of their medication. So I had one case, which is quite funny. We prescribed furosemide for one of our patients. She went to the pharmacy at the hospital to pick up the medication and then came right back, just completely distressed, saying they had given her the wrong medication, and most of our patients were actually unable to read. And so she was used to getting a furosemide packaging in an orange box, and she was given a green box. So she was adamant that they had given her the wrong medication. I told her, it's okay, it's the same medication, it's just a different packaging. But I was actually quite pleased that she was able to at least notice the difference. She knew that this was different than what she was used to. And she came to me and we talked about it, and she was reassured. And I think that was the highlight of my day. Another thing that we did was we had a research seminar for our patients, because I saw them in clinic, very short visits, and they had a lot of questions. So the seminar was an opportunity for us to go over the disease, go over the pathophysiology, go over the potential recovery rates and how good they are when we work together to make sure they're on the right medications and that they're compliant. And they were able to ask questions, see other patients who had similar diagnosis and knew they were not alone. A lot of them became friends. We had community health workers who came and did presentations on family planning, which was very important for this community. And we had medical students who did some financial counseling as far as, saving money so that they could afford to buy the MRA from the private pharmacy if they needed it. We also had psychologists who came, and they were going to have group counseling because coping with the disease was a struggle for many of these women who were used to being, very physical. And I don't know how familiar, you are with African communities, but a mom is the center of the home. She is the one who takes care of herself, the kids, the farming, if it needs to be done. Everything revolves around mom. So if mom is out of commission, things tend to fall apart. And then mom feels guilty that she can't keep up because now she's not a productive member of society. So it's actually quite distressing. So I think the psychologist was able to provide some reassurance. And as they felt better, they also, emotionally felt better too. Physically and emotionally, they were improving. And then we also asked for family members who could come to the appointment, especially the spouses. So they also would come and we could answer their questions, because a lot of them, when the wife isn't able to keep up, they start to, sometimes look elsewhere. They're like, well, why can't you do this now? There was not good understanding of the disease among the family members. So it was very helpful to have the husbands there or their significant others. And we'll just go over the disease and say, look, she won't be able to do what she used to do before, but with time it will get better. And I think that helped a lot. And then family planning was discussed at every visit, especially with the women whose LVEF had not recovered back to normal. So those were our management strategies, what we did. And then next thing I'm sure you want to know, so well, what happened? Well, this is what happened. So at baseline, when we saw them, the use of GDMTs was actually quite low. And of those who were on GDMT, their titration rates were even lower. Most of them were on the very lowest dose. After 6 months of of our intervention, we saw that the rates of use of the beta blockers and the ACE inhibitors doubled, and pretty much all the medication use improved significantly. And because of that, I think, so did the ejection fractions. So at baseline, the average LVEF was about 36%, 6-month follow-up, the average EF was 49%. And I have to say that about 50% actually had EF greater than 50%, and every one of them had improved somewhat. So even though this 49% is still less than ideal, more than about half, not more, about half of them had normal EF at 6-month follow-up. And also their functional classification improved significantly from class 4 to the vast majority were class 1. So I think that was an amazing intervention and outcome, and the patients felt great, and the family members were happy. The husbands would come to clinic with them, engaged. Always not very happy when I told them I could not see them as my patient. That was actually here to see their spouses, but it worked out. So there were some limitations to this study, clearly. One is that we were unable to recruit as many people as we would have liked, again, because access to the hospital during COVID was limited. And I was unable to travel around the country much for the same reason. Another limitation we had was that we could not obtain coronary angiograms on our participants because it was not available at the hospital. We did get very good histories, EKGs were checked. None of them had any evidence of acute or prior MIs. They're otherwise young and healthy women, so their risk was actually low. So that was what we used as our marker for non-obstructive, for the absence of any obstructive or non-obstructive coronary disease. And I think those were the major limitations that we had. So our findings were accepted and was published about 2 months ago. We're all very excited, and we hope that this will be the beginning of things to come. And on that note, what are our next steps? Well, I think we have a lot of opportunity here to make interventions, I think, that would have good outcomes. One of the things that we noticed was that there was a delay in diagnosis. Not in all, but in some of the women, especially those who were coming from other facilities. They were the ones who came in with the LVEF was quite low, biventricular dilatation, and they did not improve as well compared to the others who were diagnosed earlier. So opportunities for us will be to reach out to the community hospitals and clinics who see women in the postpartum period, especially in the post-delivery clinics, the OB clinics, and have some training on how do we recognize the symptoms of heart failure? How can we differentiate the symptoms of heart failure from the usual symptoms women have in the later stages of pregnancy or in the early postpartum period? So that's one opportunity for us. Another opportunity is to empower community health workers, physicians. There's only a very small handful of cardiologists in Zambia. The vast majority of care is provided by family medicine or internal medicine physicians. And they're, rightly so, a little nervous about initiating GDMTs and titrating them, which is why a lot of the patients were not on any, on just very low doses. So how do we empower them to be comfortable in prescribing these medications and titrating them? So that is one opportunity for intervention for us. And then also, how do we make sure that the medications are being prescribed and the titrations are being done appropriately? So what we're working on now is an implementation science project where we're going to engage the medical community, the physicians, the community health workers, the nurses, and the patients themselves, in addition to hospital administration, maybe even government officials who actually purchase these medications, and see what are your barriers and facilitators to meeting these goals, to diagnosing early, prescribing and titrating medications. What is it that limits you, inhibits you from doing this? And then we, together with the community, come up with a plan of intervention, and then we'll test the intervention with a pilot study, and then hopefully disseminate on a wider scale across the nation in the future. So that's the next steps initially. But being the overachiever that I am, I think, well, what about heart failure in general, right? Heart failure is a problem in Africa because hypertension is a problem in Africa. Could we replicate the work we have done here to address other etiologies of heart failure in sub-Saharan Africa? So we have data to show that hypertension is a problem. So this was the HF study. It was a large population study that was done between 2007 and 2010. Involved 9 African countries, and they again wanted to get an idea of the phenotype of patients with heart failure. And what they found was that hypertension was the leading cause of heart failure in sub-Saharan, in those 9 countries and those communities, and that the mortality was actually quite high. So another thing that was noted was that the patients were actually diagnosed at a very young age. I say young, very young, because I am, I'm older, so 50 is very young for me. So most of them were diagnosed around 50. That was the average age. And the diagnosis, the EF was around 39%, and the 6-day mortality was about 11%, which I think was quite high. And on admission, they were all placed, or not all, a large proportion were placed on ACE inhibitors and MRAs, not so many on beta blocker. Digoxin was used quite frequently, and loop diuretics. I think that these numbers show what happened in the hospital. When the patients leave the hospital, surprisingly, this study had 7% loss to follow-up. But when they leave the hospital, a lot of them continue on the very low dose that they were initially placed on. They're not being titrated. Some of them don't come back once they run out of medications, or they have to work, or they live too far away to the health center. So I think getting this care to where the patients are is going to be very important, because Africa is of course a huge continent, but the countries themselves have very concentrated populations, in the sense that if you go to Lusaka, the capital of Zambia, you have a large hospital there. But if you out of Lusaka to maybe in the north, very north or very south, they may have a small clinic in the community or in a village somewhere. So how do we get this care to those people and have the community health workers be comfortable providing this care for them? So I think that's the big picture that I am envisioning. And then this is the inter-CHF study, which was an international study, again, describing the phenotype of patients with heart failure in Africa, China, India, Middle East, and in South America. And what they noticed, again, was that hypertension, this is among the African cohort, this figure is describing the African patients, hypertension was the leading risk factor for developing heart failure. And among the group, this is the African cohort as far as the medication use at baseline, we see that ACE inhibitors or ARBs were used very well, and diuretics were also used, but the rest of it, I think there's room for improvement. So do we think that just fixing hypertension, even for PPCM patients, we saw that gestational hypertension and postpartum hypertension was common. Could that be the driving force in Zambia for PPCM? If that is the case, should we just treat everybody who has hypertension, or the women? We should be treating everybody with hypertension, but should we aggressively manage hypertension among women of childbearing age? I think these are things that we should explore. And I think that's all I have to present for now. I would like to thank my great team, Professor Faston Goma, Professor Wilbur Mutale. Those were my Zambia mentors, Professor Doug Heimberger, who was my Vanderbilt Global Health mentor, Dr. Julie Dab, who was my clinical mentor, and the VCD staff in Zambia and at Vanderbilt, and also the University Teaching Hospital in Lusaka, the staff, the trainees, the physicians, just amazing. And more importantly, I want to thank the patients for participating and allowing us to be a part of their care. And they're still messaging me and asking me when I'm coming back, and I keep telling them soon. This work would be impossible without my research nurses, Sister Jane Musho. She was amazing, very patient. Also my interpreter, Sister Neva and Sister Chinza, were all amazing. And it took a village definitely to get this work done. And for that, I am very grateful. And these are my references. And I will stop sharing now and open for any discussion. Thank you for your time.
Thank you, Dr. Strasserking. That was really outstanding. I think it's amazing work to not only identify the problem, but then develop interventions to make it better. I want to remind everyone that if you have questions, please post them in the Q&A section within Zoom. And we do have a few questions already. So the first question is, do you have any data or information to share regarding a polypill for heart failure, or specifically PPCM?
I'm sorry, can you repeat the question? I couldn't quite hear.
The question has to do with a polypill. So do you have any data or information to share regarding a polypill?
Oh, wow, that would be the answer to so many questions. I know I personally have no data to show any work on polypill, but I do have a colleague of mine who's working on polypill for heart failure in the work is being done in Kenya. So we're hopeful that we can get some positive data from that, and this will alleviate a lot of the problems we have with medication compliance and access. So yes, we're looking forward to it for even the polypill for hypertension, which I've been hearing some words about here. So I am definitely open to collaborating if that is something that's in the works.
Great. Okay, another question. What advice do you give regarding ACE inhibitors and the risk for another pregnancy, not just for PPCM, but also for ACE inhibitor fetal side effects?
Yeah, so ACE inhibitors are contraindicated in pregnant women. So if one of my patients who has recovery of the LVEF decides they want to get pregnant again, we do counseling. We will slowly wean them off the ACE. If they're at that point, there should be a lower dose of ACE if the EF is normal. Wean them off, repeat an echo in about maybe 3 months. And then if it's still normal, then they can go ahead, letting them know they cannot be taking ACE or ARBs during pregnancy, but it's safe to use with breastfeeding.
Great. Well, that's all the questions in the Q&A section right now. Maybe I can ask a quick question.
Sure.
You know, I'm an endocrinologist, and every friend I have who's a cardiologist just keeps talking to me about SGLT2 drugs. And I understand the heart failure data is actually very impressive. How can drugs like that are fairly new and expensive, how can the patients that you saw, how can they get those drugs?
They cannot. That is the main challenge here. As you on my slide, I did, they're definitely great drugs. They're indicated for this problem as far as heart failure, but they don't even have them in Zambia. So the patients who can afford them will probably go to South Africa and get the drugs from there. But most countries don't even have them on the formulary, right? So I think maximizing the utility of what we have that is accessible and affordable is what I think we can focus on for now until we can get those drugs cheaper and more affordable for not just LMICs, but even poor communities here in the US.
It's a fair point. One new question came in. Can you speak to building trust in this community in an area where there are several sensitive components, as you discussed?
Yeah, that is a great question. Trust building in global health is key. There's a tendency, I think, for us to leave the US or Europe and go to low LMIC countries and feel like we have the savior complex, we're going to fix the problem, we're going to do this. When the reality is that there's a lot of people who are already equipped to handle the problems, but they just don't have the resources. So my goal was definitely to engage the hospital staff very early on. I had mentors in the community. We made decisions together. I did not go and impose my will because these are highly intelligent individuals who can do this, they just need some help. Made decisions together. We had meetings, we collaborated. I was very flexible. I saw patients who were not PPCM patients. I did echoes on everybody because they were overwhelmed. I think putting yourself in a position where you're serving builds a lot of trust as opposed to putting yourself in a position where you're trying to rule or lord over people. So I think going there with the mindset of serving was what worked for me and just helping.
Great, thank you for sharing all that insight. It looks
it's
like
my pleasure.
Yeah, that's all the questions we have. So thank you again, Dr. Strasserking, for kicking off our Global Diversity series. That was a fantastic talk and I learned a lot.
Thank you very much for having me, and it's been my pleasure.